afternoon. This is Dr. John Bennett broadcasting from sunny Miami, Florida. Today we have another in the series as part of the conference of neurosurgical TV brain tumors. And we have the pleasure today of having Kristine Ravina. She's a MD neuroscientist from Stanford, where she's doing research in the Stanford in the neuroscience area, and she'll tell us about that. And we're also graced by the presence of Slaven Goljovic. He's a medical student from Croatia. Hello, Slaven.
Hello, everyone. My name is Slaven Gojkovic. I'm a medical student in Zagreb, Croatia, and I'm enrolled in some student societies in neurosurgery, and I'm looking forward for this presentation. Thank you.
Welcome, Slaven. And okay, Christina, welcome. It's all yours.
Hello, it's nice to meet you. It's a great honor to be here and be able to present and share my opinion. So my name is Kristine Ravina. I'm currently a postdoctoral research fellow at Stanford University in neuroscience, and generally my research currently is associated more with the stroke and the possibilities to improve the recovery after the stroke, but my general interest is in the research and in the medical careers associated with the neurosurgery. So my past research, since I'm initially from Latvia, it was associated with brain metastases, and now today I'm going to be happy to share some recent news and recent opinions and paradigm shifts in the area of cerebral metastasis treatment in neurosurgery.
Very good, Kristine. Could you go on with your presentation, please?
Yes.
Very good.
All right. So, just a second.
Very good.
So the name of this presentation is the Cerebral Metastases, the Paradigms and Prejudice. And the picture I choose for this presentation, actually maybe some of you are already familiar with that. It is the myth of the Sisyphus. This is a Greek a figure from the Greek mythology, and as you probably know, the Sisyphus was punished by the gods of the Olympus so that he had to push this giant rock up to the hill just to see it roll back down, and so that he repeated, probably repeating all this thing all over again, and this was his punishment for the trickery towards the gods of the Olympus. But how I got there was actually this very amazing editorial on which I actually ran onto accidentally. This is about the technology in the resection of gliomas and the definition of madness. The author of this editorial is Dr. Patrick Kelly from the New York University. It was published back in 2004 and was published on the previous article about intraoperative stereotactic guidance using MRI spectroscopy. And what was very amazing about this editorial and what made it so very archetypal is how the Dr. Kelly actually shared his opinion and experience in the treatment of cerebral glioma, and what he defined as a madness is what someone has defined as a madness is doing the same thing all over again many times in the same time, expecting the same results. And he transferred this idea into the treatment of cerebral gliomas, and also on this article about MR spectroscopy as one of the tools which helps us to define the borders of the tumor, the presumable borders, so that we can resect it more precisely. And he reflected on this idea, saying that he's experienced in his practice that actually this endless striving to define the borders of the cancer probably is actually even useless, because as we know, it's very difficult to draw exact line around the tumor in the brains, because it's spreading and the cells are there and there is no certain line. So it's usually, if it's invasive, so that we can't really draw it. But what was actually even better, it was the answer of the authors of this article, which were the doctors from Austria and Germany, and they answered with a very actually philosophical, in a very philosophical way, and they were actually citing the work of Albert Camus, the myth of the Sisyphus. And although they recognized that this fight towards defining the tumor borders and trying to resect it as precisely as possible, although still the survival of these patients is pretty low, and it's around like maybe 6 months still, even though we're still striving to make our approaches safer, so that we can at least try to prolong those, at least for a few months, the life of those patients, because behind all of those cases, those are the personalities and the human beings. And our goal possibly is, our main goal is still just to try to make their lives fulfilled and prolonged. So actually this idea, and the Albert Camus, which is an existential philosopher, a French philosopher, and he's known of his philosophy of absurdism, and what they actually also emphasized is that the Albert Camus, he recognized this fight of the Sisyphus possibly not that negative as we were used to see it, because he said that the fight itself toward the summit suffices to fill a heart of man, and one must imagine Sisyphus happy. So that's possibly more about the process and the conscious recognition of the process, which is actually most important, not getting from point A to point B. And on this note, I would like to continue about the cerebral metastases. So here, in this diagram, you can see that there are about 1.7 million people every year in the United States diagnosed with a cancer. About 40% of those patients will be eventually diagnosed with the cerebral metastasis, and 0.17 million of those only will eventually get the surgical treatment. And here we see that there is a very high variety of different types of tumor which can metastasize to the brain, starting with the most common one, which is the lung cancer, following with the breast cancer in 20% of the cases, and then melanoma in 15% of the cases. But still there are such types of cancer like kidney, gastrointestinal, which is namely the colorectal carcinoma, and even other more rare types of the tumor. But this is not everything, because we still can subdivide these types of tumor into histological subtypes. As we know, for lung cancer, there is a small cell lung cancer and non-small cell lung cancer, which can be further divided into squamous type of cancer, into adenocarcinoma and large cell cancer. For the breast cancer, we know that there are also many actually histological subtypes of invasive carcinoma, like tubular, ductal, invasive lobular, infiltrative ductal, mucinous, and medullary. And we also know about the molecular subtypes of the breast cancer, which even further divide this type of cancer into other subtypes like laminal A and laminal B and triple negative based on the status of estrogen, progesterone, and quercetin receptors, which basically define the sensitivity of those tumors to the chemotherapy. And actually, we're taking all of this together and defining this as the metastasis to the brain. But actually, we can see that there is this very high variety of different types of tumors. So talking about the treatment, so two general, we could say, modalities is the surgical treatment, and then there is the radiation treatment. So for surgical treatment nowadays, we have all those different add-ons for the surgery like neuronavigation, tractography, intraoperative sonography, and CT and MRI modalities, awake craniotomy, and some of the sensory evoked potentials, direct brain stimulation, which can help us to separate the tumor and understand its relation to the functionally eloquent brain areas so that we can do the resection as precisely as possible and sparing the eloquent and important areas of the brain. On the other hand, we have the radiation treatment, which can be largely divided in two parts. This is the fractionated external beam radiotherapy, the whole brain radiotherapy, or stereotactic radiosurgery, which has also several subtypes, including the linear accelerators and gamma radiation sources, exploiting gamma knife surgery, which and these two differ basically that one of them has the external gamma radiation source and the other one is exploiting the acceleration of the electrons, which can be then used for the treatment of the eradication basically of the intracerebral tumors, and also the proton beam type of treatment, which is another modality, but actually there's no strong evidence that one of these options is actually more effective than the others. So basically, we can all of them put under one label, which is the stereotactic radiosurgery, which is the type of surgery which means there's a high concentration of radiation which is directed to a very precise point into the brain where the metastasis or the tumor is, so that the surrounding tissue is doesn't get that much radiation. And the fractionated external beam radiotherapy aims to delivering the radiation to the whole brain, so that means that the certain amount of radiation hits mostly all of the brain areas. Of course, the concentration of radiation there is less, and the mechanism how it works is also different, because here it depends on the difference between the possibility of normal tissue to respond to radiation cause damage versus the tumor tissue, which is more sensitive to this type of damage, so that over the period of time, by delivering this treatment in many fractions, eventually we predict that the tumor cells are going to die and be more sensitive to the radiation treatment, whereas the stereotactic radiosurgery is a high concentration of radiation, which basically eradicates the tumor at the very its location. So here for the surgical treatment, we know that the main goal of the surgery for cerebral metastasis in any type of tumor, actually, it is the gross total resection. And there are several types of resection, but basically we're aiming for if the tumor is close to the cortex enough and its size allows, so we do the gross total resection. We avoid piecemeal resection because it may spread the tumor cells, and we're trying not to sever the tumor capsule because it also can promote the spread of the tumor cells into the surrounding tissue. But of course, not always it is the case, because the the size of the tumor, the location of the tumor, how deep it is in the brain, and how it is related to the functionally eloquent areas is also very important. It defines our approach and the possible effectivity which we can actually achieve with the resection. So actually we could go first to this slide. So from the surgical perspective, there are several clinical situations which we can define. There are certain factors which promote the treatment to be the surgery or the stereotactic radiosurgery. So usually, as we know, the radiosurgery is reserved for the lesions which are less than 3 centimeters in size, and their number is no more than 3. So actually nowadays this idea has been shifted towards even probably less, so that we should probably put the threshold even less than 3 centimeters, because as we increase as the tumor size increases, the concentration of the radiation should go up as well in order to eradicate that tumor, and also the risk of the surrounding tissue to receive a certain dose of radiation also increases. We know there are several the structures in the brain are not sensitive to the same degree to the radiation. For example, the cranial nerves, including cranial nerve 2, 7, and 8, and those are very sensitive to the radiation, and so that at some degree, when the tumor size is above 3 centimeters or possibly even above 2 centimeters, the dose of the radiation and the risk of the surrounding tissue to be damaged actually also increases. But even above 1 to 1.5 centimeters of the tumor size, the effectivity of the stereotactic radiosurgery drops pretty steeply, so that there has been discussion about that whether we probably should decrease this threshold. And also the surgery is a favorable treatment option for the tumors which are located in favorable areas, which are close to the cortex, which don't involve the eloquent areas and are not very deep inside the brain. And also, of course, the need for the biopsy and the histological confirmation of the type of this tumor also drives our selection towards the surgery, as well as a very important factor is the size of the tumor and the associated symptoms and the neurological deterioration which can be associated with this, which is like the generalized edema, the midline shift, and so basically we define those as life-threatening metastases which are producing this type of symptoms. And also if there is one metastasis out of several, which is the main one, which is producing the symptoms, of course we are aiming our resection towards that lesion so that we can relieve the acute neurological deterioration. So generally right now for the solitary metastases which are symptomatic and accessible, we use surgery and whole brain radiotherapy. For asymptomatic and smaller or inaccessible lesions, we try to use the stereotactic radiosurgery if the size of the tumor and the location allows that. For multiple metastases, the role of the whole brain radiotherapy and stereotactic radiosurgery increases, and this is about which I'm going to talk a little bit later. So as we notice here, the borderline is the stable systemic disease and Karnofsky performance status above 70, which tells us about the prognosis, and it actually also defines the aggressiveness of the treatment which is needed for the certain situation. And here, so the Karnofsky performance status is the tool of functional assessment, And generally, we know that above 70 it includes these three subgroups of patients, and the common thing for them is that they are able to carry on normal activity and they're able to work and they don't need any special care, as well as, of course, at lower numbers we still see some signs and symptoms of the disease. And several clinical trials at the end of 80s and 90s, the beginning of the 90s in the past 20th century, those clinical trials allowed to develop this radiation therapy oncology group classification, the recursive partitioning analysis, which allows to group the patients into three groups, which actually defines their prognosis and the survival very well. And this is some sort of a golden standard currently, and we don't have anything that could be better in the prognostic aspect. So here we see that the Karnofsky performance status is one of those factors, which is if it's 70 or more, so it indicates most likely better prognosis and higher survival. Also, age below 65 years, the status of the systemic disease is very important as well as the fact of other metastatic sites. But of course, the majority of the patients fall under the class 2, which we can say has intermediary survival prognosis between the class 1, which has the best prognosis, and class 3, which has the worst prognosis, which depends solely on the Karnofsky performance status below 70. So also another factor which we should consider looking at the brain metastases is their sensitivity to conventional fractionated radiotherapy. So we know that the most highly sensitive cancer types are the small cell lung cancer, which is a subtype of lung cancer, the germinal cell tumors, the lymphoma. Intermediary sensitive are the breast cancer, non-small cell lung cancer, and colon cancer. And then there is a group of types of cancer which are poorly sensitive. Of course, first of those is melanoma, which we know very well about the struggle with the treatment of this debilitating type of cancer, the renal cancer, and the sarcoma. But in the same time, although these cancers are not sensitive for whole brain radiotherapy, they're very sensitive to stereotactic radiosurgery, because as we know, there are different types of mechanisms how these two types of radiation treatment modalities affect the cancer. So talking about the whole brain radiotherapy, there have been trials of this radiotherapy oncology group in 70s and 80s that showed increased patient survival with multiple metastases from 1 to 2 months to 3 to 6 months, which is approximately 3 times more when the whole brain radiotherapy in the form of 30 grays were delivered in 10 fractions. So this type, the whole brain radiotherapy, is nothing new and has been known for even more than 60 years. And it's been generally recommended after surgery or stereotactic radiosurgery to eliminate micrometastases, which can be disseminated within the distant brain areas. And this is what I talked in the beginning about the fact that we actually cannot draw a distinct line between the tumor tissue and the normal tissue, and then there is this gray area where there is certain amount of the tumor cells still present, and this number of tumor cells also differs based on the type of the cancer and the type of the mutations, the molecular classification, which is even further, more fine type of classification, which is gaining more attention nowadays, actually. And there were several randomized studies which are considered to be landmark studies of patients harboring single metastases. In 1990, the study of Petchel et al., the first study of which was a randomized clinical trial, which proved actually that surgical resection plus whole brain radiotherapy was beneficial over whole brain radiotherapy alone for survival increase, which was about 3 times actually, which is very significant. After that, in 1998, the same author collective with the Petchel et al. Proved that the surgical resection plus whole brain radiotherapy was beneficial over the surgical resection alone and local recurrence control. But unfortunately, it did not translate into survival improvement. And in this situation, also 61% of patients in surgery-only group eventually received salvage whole brain radiotherapy for recurrence. And also, we should pay attention to the fact that these studies were conducted on the patients which had Karnofsky performance status of 70 or more, and they had controlled systemic disease, which actually is not the case for the majority of the population, since, as we recall, the most of the patients fall in the category of RPA2 class. And most of those studies are conducted mainly on lung cancer metastases, which also is just a subset of all those different types of cancer which can actually and do metastasize to the brain. But the very important factor about a whole brain radiotherapy is the fact that we can observe a chronic neurocognitive sequel after 6 to 12 months post-treatment, which is called the chronic radiation toxicity, and it tends to cause the leukoencephalopathy, the radiation-induced leukoencephalopathy, which causes neurocognitive deficit. And this factor is being actually investigated very actively nowadays, and I'm going to talk about a little bit more, which actually limits the use of whole brain radiotherapy. So for pathophysiological mechanisms of whole brain induced cognitive impairment, of course, we know that the effect of the radiation is complex, and here are multiple factors, including the oxidative stress, the inflammation, the effect of on the physiological angiogenesis, and the effect on the stem cells. And we know that there are several niches of stem cells in the adult human brain, and which can be affected by the radiation treatment and eventually cause chronic deterioration, and also eventually the impaired neurogenesis. What is the consequence of that? So we already know that whole brain radiotherapy, first of all, it's better than doing nothing, and it increases survival significantly in comparison to just an observation. Next, we also know that whole brain radiotherapy in combination with surgical resection is better than surgical resection itself only. And recently there have been clinical trials also evaluating the stereotactic radiosurgery with or without whole brain radiotherapy for 1 to 4 brain metastases in this case. And this was a meta-analysis of those clinical trials. So there have been these 3 trials from 2006 to 2010 with variable number of patients. And here, eventually, what was concluded is that the patients 50 years or older or less showed survival advantage with SRS alone versus SRS plus whole brain radiotherapy, and they did not show increased risk of new distant metastases with SRS alone, while beyond 50 years of age, the risk of developing new distant metastases increased significantly. So here if we look at the results, so actually we see that out of 364 patients in SRS alone group, there were only 31 patients, and SRS plus Wholebrain radiotherapy, only 37 patients out of 364. And if we looked at the cancer types, we see that the distribution of different types of cancer is quite different. And for example, the lung cancer is 2 times more prevalent in the SRS plus Wholebrain radiotherapy group. The kidney cancer is not at all represented in this group, and we know that the kidney cancer is relatively radio-resistant, which may actually skew the results. And also the percentage of RPA classes and the percentage of females and males is different. So actually, what I saw in one of those, in one of the review articles, is that they compared this type of putting all these clinical trials together as comparing apples to oranges. But actually, it seems like it's more, it sounds like more a basket of fruit, which we are actually comparing to each other, because there are so many different types of cancer and they are put all together in the clinical trials. There are still some of the studies which don't even specify the type of cancer, and which just basically put all of them together without any possibility actually to further divide and look at the results in the subgroups. So looking separately on these three studies which were compared in this meta-analysis, so the first one of Aoyama et al. In 2006, it looked at 1 to 4 metastases, and they concluded that the local tumor control for the group with added Wholebrain radiotherapy was superior, but still it didn't translate into increased median overall survival. The neurocognitive function was optionally assessed, and in only a very small subset of the patients, without a clear definition of follow-up time points. And also, if we look at these results, in some of the studies I've seen that they actually try to translate this into some improvement, because we see here it's an SRS only group, it was 27 points, and after that was 28. But as we know, Mini-Mental Status Exam, actually the mild cognitive impairment starts from 26 points, which is actually not even represented in these results. We can't even tell that these patients actually had any type of cognitive deficit. Then if we look at another study of Chang et al. From 2009, so there they looked at patients harboring 1 to 3 metastases, and at 4 months actually they looked at the neurocognitive impairment, and they saw the significant decline in learning and memory, and they used specific questionnaires which can objectively tell about the quality of life and specifically the neurocognitive function. And actually this study was even terminated prematurely because of these very negative results and of the patients who had Wholebrain radiotherapy. And still, despite improved local control in these patients, we don't really see an increase in the median overall survival. In the very last study in 2010, which was published, they also concluded that Wholebrain radiotherapy reduced the probability of intracranial relapses, but it still did not translate into prolonged overall survival or into a prolonged survival time without functional independence. And unfortunately, no assessment of cognitive functions to evaluate late neurotoxicity were performed. So overall, there have been multiple studies, and there have been overall 5 clinical trials comparing SRS versus SRS plus whole brain radiotherapy. And they have been looking at different types and different numbers of metastases and different composition of primary cancer. And it is very, and none of these is certainly has shown that there is a benefit in survival for the patients who had added the whole brain radiotherapy. And there have been also studies which were investigating the surgical resection versus surgical resection plus whole brain radiotherapy. And those studies have had actually a little bit contradictory results, because generally 2 of them, the one of Patchell et al. And Vecht et al. In 1993, they concluded that the surgery actually improve survival for the patients with limited systemic disease. But one study in 1996 by Mintz et al., which can be also seen in this table here, they didn't actually conclude that the resection was beneficial, but still it's not very popular because of several limitations, including the fact that much higher percentage of patients in this study actually had progressive systemic disease which wasn't controlled, and also the fact that the MRI control wasn't performed for all the patients initially. So there are several limitations, and also we should look at these results critically to evaluate the picture, how it actually looks like. And then recently there's been this study which compared the effectiveness of treatment options for single brain metastasis. And they compared the results that actually consolidated the results from 34 studies, from which not all were randomized. And looking at the primary tumor type, we can see that almost 40% of them did not even specify the primary tumor type. And of course, the majority of the ones who specified showed that the lung cancer was the most prevalent type, which is the most common cancer, which metastasizes to the brain, but still there are other types of cancer also contributing. And what is also concerning is the quality of life assessment, which was mainly in the form of a Karnofsky performance status, which we discussed already a little bit earlier. And as we know, the Karnofsky status is a functional score, and it actually, as we know, the quality of life, it actually consists of 2 modalities. First of them is the functional modality, which can be assessed by scores and the functional scoring systems, and the other one is psychosocial dimension, which is actually subjective, which can be assessed by the patients themselves and their caregivers. And even though they used mostly the Karnofsky performance status, this is what was used in most of those studies, they couldn't even have absolute differences in this in these scores, because some of the studies did not report the actual scores, just labeled them as increased, decreased, or not changed. And they recognized that this data is actually heterogeneous and inconsistent. And here, what they concluded was actually they looked at the cost, efficiency, the efficacy of the method and the quality of life in the form of mostly the Karnofsky performance status, and they saw that by different types of analysis that the surgery plus stereotactic radiosurgery was in the first position in rank for efficacy, while whole brain radiotherapy was first in the rank for cost effectiveness. But what is interesting, that the highest quality of life was actually for patients receiving SRS plus whole brain radiotherapy, which is a little bit questionable because of knowing that what criteria were used for the quality of life assessment. So, as I mentioned before, so quality of life, as we know, it consists of two general dimensions. And actually, the psychosocial dimension is the one which depends on the individual patient, on the individual support systems, on the functional, the level of the functional of the patient. Because if we compare a person who has a very high level of functioning prior to the disease, the deficit which would be experienced by that person, of course, will be more prominent than the person who had the lower functioning level before the disease. And which one eventually matters the most? I think that the intuition actually tells that the psychosocial dimension, the subjective, self-reported quality of life reported by patients and caregivers is what matters. Because as we know, a human being and a patient, it's not a sum of functional scores and assessments. It is a personality, and each of them is individual with its individual background, which should be taken into consideration when we look at the quality of life. And there has been this study which was actually interesting, which was a little bit about different topic, about the decompressive hemicraniectomy for malignant middle cerebral artery infarction, asking, is life worth actually living? So as we know, this type of treatment is given for, is considered for the patients in the aspect of malignant infarction, and it leaves many patients with very profound neurological deficits. And they ask the patients and ask the patients themselves and their caregivers whether they were satisfied with their lives, because there has been this question whether we should use this treatment at all if it leaves so many patients with a profound neurological deficit. And actually we saw that they saw that majority of patients, regardless of despite actually the very the neurological deficit, they were still satisfied with their lives. And the conclusion was that the life was actually worth living, and we just can't look at the functional assessment and the neurological function in general, or just look at the functional assessment, because actually the personality and the patient behind each of those cases is what matters and what makes actually the decision whether the life is worth living. And to continue, the adjuvant whole brain radiotherapy after surgical resection of single brain metastases, many in this study, what I actually liked is that the emphasis they put that despite class 1 evidence, which was first actually delivered with Petchel et al. Study favoring adjuvant whole brain radiotherapy, many oncologists still withhold this therapy after resection of single metastasis, based at least in part on the premise that the results are not necessarily applicable to all the patients. As we know, there are different types of tumor, and mostly the study was based on the lung cancer patients. And what they looked at is that, and what they concluded in this retrospective study of 358 patients, in order to investigate whether radiographic and histological features influence the effectiveness of adjuvant wholebrain radiotherapy, they concluded increased that the resection significantly increased the local recurrence for metastases more than 3 centimeters in diameter, and increased distant recurrence patients with active systemic disease. So, and the wholebrain radiotherapy reduced recurrence regardless tumor histology and radiosensitivity, but here they specifically looked at they compared the melanoma and lung cancer. So that this probably tells us that this withholding of wholebrain radiotherapy for patients with increased metastasis size and progressive systemic disease, active systemic disease, actually is making even more harm. So probably this is the subset of patients for which we should use wholebrain radiotherapies, the size more than 3 centimeters and the active systemic disease. Although they didn't see actually the effectiveness, the difference in the tumor histology in terms of responsiveness to wholebrain radiotherapy and this ability to reduce recurrence, it still was a retrospective study, and they did not separate the subtypes of lung cancer, and they did not also look at the cognitive function assessment. And also, if we look at these patients retrospectively, so it's still this argument is there that the oncologists and the treatment teams actually preferred wholebrain radiotherapy for patients with possibly lower, with more active systemic disease, and less of those patients actually who had radio-resistant tumors. Less of them, of course, received wholebrain radiotherapy, because we know very well that probably it would be actually useless to use in those patients. So that's the minus of retrospective study that we can see here. And one of the latest reports, which was mentioned in the Association of Clinical Oncologists meeting in 2015, there's been this phase 3 randomized trial of wholebrain radiotherapy in addition to stereotactic radiosurgery, which was actually aimed to investigate the effect of wholebrain radiotherapy on the cognitive function. And their primary endpoint was cognitive progression, defined as a decline more than 1 standard deviation from baseline in any of 6 implemented cognitive tests. So a significant number of cognitive tests. So, and it shows the concentration of the study on the cognitive function, which has shifted actually our emphasis in clinical trials, which was initially only about the prolongation of the survival and the technical effectiveness. And what they concluded is that adding an adjuvant wholebrain radiotherapy to stereotactic radiosurgery does not increase overall survival still, despite improved local control. Furthermore, it associates with higher incidence of cognitive decline, namely the recall and verbal fluency, the ability to learn. So that the local control and the fact that there are no new metastases occurring in the brain, it doesn't necessarily mean that the survival will be better. But by adding this type of treatment, the wholebrain radiotherapy, for highly functioning patients before the disease, it associates with possibly lower quality of life because of these cognitive side effects, which are pretty prominent and also proven in this clinical trial eventually that whole brain radiotherapy should actually be delivered to the specific subset of patients which can actually benefit of this type of treatment. And one of the very good, in my opinion, papers is by Dr. Konzolka et al. In neurosurgery in 2014, where they consolidated different results from all these clinical trials and put the title as "It is time to evaluate the management of patients with brain metastases." They emphasized the use, the concentration on tumor histology, which is very important as we discussed earlier. So, and even knowing the advances in medicine and research, to knowing different molecular subtypes of tumor, and there may be even different molecular subtypes of tumor in one single metastasis, which can drive the prognosis and the behavior of that tumor. And the second of the factors or the misconceptions they elucidated is that the number of metastases matters the most, which is actually logical because, well, first of all, it's easy to count the number of metastases, but actually there's a difference if we are looking at like 2 metastases in the cortical area or 2 metastases which are deep inside in the brain or in the brainstem, for example. Those are 2 different types of cases, which and if those are different tumors, they may have different ability to cause edema and a different prognosis as well. And what they propose, it is actually, and it was shown in several other studies, that the actual tumor volume, not the number of metastases, is what matters. About the micrometastasis, which was the argument for using whole brain radiotherapy, was the biggest argument for using the whole brain radiotherapy. Actually, as we see, the use of this modality of treatment does not translate into increased survival. And in the same time, it actually causes the neurocognitive decline at 6 to 12 months. And nowadays, when the systemic treatment of the cancer has been improved and patients tend to live longer, this question and this problem is being even becomes more and more actual because of the subset of patients who experience the cognitive decline increases. And the harm of whole brain radiotherapy, like I mentioned before, and we looked at different clinical trials, it seems like whole brain radiotherapy possibly we shouldn't go away from using this type of treatment because it still gives us survival increase and in certain situations, and it may be beneficial, and it is beneficial for patients with multiple metastases, and it depends also on the status of the systemic disease. And also what they emphasize is the role of the screening and asymptomatic metastasis, because nowadays the technological advances has gone this far that we are able to see very small tumors before even they give us any symptoms. And this is very important, and this also increases the role of stereotactic radiosurgery as a modality of treatment for small metastases. And also, of course, there will always be the question of whether we should do surgery on a patient who doesn't have any symptoms, but knowing if there is systemic cancer which has been already metastasized to the brain, and we're looking at those patients, and we know their prognosis. So in those cases, maybe it's favorable to use the stereotactic radiosurgery. So, and concluding about the whole brain radiotherapy, in association of clinical oncologists in 2015 in a meeting, they discussed this issue and discussed the last clinical trial about which I mentioned, which evaluated specifically the cognitive deterioration of patients which received this type of treatment. And one of the questions was that actually the burden of proof is now switched, and the question is, can we prove that whole brain radiotherapy is beneficial in a subset of patients, which most likely is the truth. And we also should look at the deterioration of brain function, of the neurological function, which can be brought by the tumor progression itself versus the radiation-induced leukoencephalopathy, which is caused by whole brain radiotherapy. And this is where we should probably look at the functional levels of the patients and the quality of life. Also, there are possibilities of decreasing the toxicity of whole brain radiotherapy by using neuroprotectants. Currently, there have been studies evaluating NMDA receptor agonist memantine. Although they didn't get the statistically significant results, there is a tendency for this treatment to decrease the deterioration of the neurocognitive function. Now, so there is a possibility of avoiding the stem cell niche in the hippocampus subapendymal layers, so that that also has a potency to prevent the neurocognitive function deterioration. And maybe whole brain radiotherapy, and it still should be used as a salvage therapy. And this is how it is being actually used for the patients which have been treated initially with surgery or stereotactic radiosurgery, which develop the relapse, the recurrence of the metastasis, and eventually they will require the whole brain radiotherapy, which can still prolong at least for a few months the survival of those patients. And so the further directions, and what was actually also emphasized in the association of the clinical oncologists meeting, is that this is the shift of the paradigm, and now we should probably concentrate on improving the patient's survival, the quality of the patient's survival, not only looking at the numbers and numbers of months which are better or worse for one or another type of treatment. We should understand what is the cognitive function and what is the quality of life of those patients who receive those at least few additional months of life, having this very cruel prognosis, which the brain metastasis patients usually have. And concluding, if we return to the myth of the Sisyphus, to the Albert Camus, what he actually looked at and what he emphasized at the end of his essay is that this myth is tragic because its hero is conscious, and but the lucidity is the factor which constitutes this torture. At the same time, Crohn's is his victory. So the fact that he is pushing that stone uphill, and he knows in the same time that that stone is going to fall and it's going to roll down, which is actually we can translate it into into the patient, this, we could say, metaphor that although we know that the prognosis is bad and that eventually the death is the conclusion which will come, and there are just few months which we can give those patients. The way and the struggle uphill itself, maybe it's enough to fill a man's heart. It's enough this way towards the group prognosis. What we can do is we can make it less negative. We can increase the quality of life and assure that these at least few months are lived fulfilled, and actually it may fill the man's heart. And what Albert Camus told at the end, one must possibly imagine Sisyphus happy as a person who is trying and accomplish his way regardless of the eventual prognosis. So that's the end of my presentation. I hope that you enjoyed it. Thank you very much.
Well, thank you very much, Kristine. You can get off the PowerPoint there so we can see your face. I love the classical illusions. One thing I'll have to say about, and I'd like to welcome Ben Milpuri. He just joined us late. He's a physician from Michigan. But we, as physicians, we basically labor at a lonely, we sweat over lonely labor, all of us. And some people would call that arduous, but to all of us, and I know for me, it's enjoyable. And that, you know, I guess it can be kind of compared to Sisyphus rolling a rock up. But, you know, a couple of comments that I'd like to make first to start things off. Is that one thing I've learned through this conference? I thought that, as a general physician, I thought that all metastases are the same, and you kind of showed that no, they're not. They're different, and you have to treat them different, and they have different survival rates. So that is one thing that I noted, and I'd like to open it up to Slavin and Ben if they have some questions or comments.
Thank you.
Thanks, Kristine.
Yes, thank you. I have a comment. I wanted to say that I have to agree with Dr. Bennett. This is really what makes you happy, to be able to do the things you always wanted to do. And I think that you put very nicely this Camus words, saying that we must imagine Sisyphus happy. But I was wondering, as an overview, can you please say what would be, in your opinion, the best treatment for brain metastasis today? I'm specifically interested into the metastasis of the fourth ventricle. Are there any differences, or how would you just underlie it all? Thank you.
So yeah, well, as you possibly can guess, this question is not easy, and there is no a single treatment. So that as we recall that Dr. Kelly wrote, the madness is doing one thing over and over again and expecting to have a different result. Here we're combining all the metastases in one cohort of patients, and we're expecting to have the same results, still doing different and many clinical trials over and over again. So it's sort of maybe reversed in this case. So what I would like to emphasize is that the fact that we should look at the patients individually and look at first of all, the status of the systemic disease, and also the functional level of the patient, and also of course the size of the metastasis, the location, and the fourth ventricle. Of course, it's not it's a pretty rare location of metastasis, and so it depends on the cancer type. If any type of radiation, like the radiosurgery, could be used, if the size of the tumor is allows the use of stereotactic radiosurgery, and of course the location within the ventricle means that there is a very high risk of dissemination through the cerebrospinal circulation, which is a known factor also for this location of cancer. So yeah, of course, a combination with systemic treatment, which can be used and which is important for certain types of cancer. We shouldn't forget about that as well.
Thank you, Kristine. Ben, do you have questions or comments?
Oh my goodness, Kristine, this is a wonderful presentation. First of all, I mean, it's amazing. That's excellent. I mean, I really congratulate you on this. And you know, this topic is really very complex, especially you know, small size, big size, this classification, that classification, patient's condition, age. I mean, you know, but I mean, the studies kind of, you know, they don't make much difference. You know, maybe they say, you know, few months survival, prolonging the, you know, but is it really, you know, extending the patient's life, or is sometimes I feel it's kind of lead time bias, maybe. You know what I'm saying? Lead time bias. Are you familiar with that lead time bias?
Yeah,
You know,
that
finding
could
it
be the case.
early and, you know,
What
treating
is
it
that?
early.
What is that?
It's kind of, you know, it's misleading. You know, like, you know, if you diagnose the patient earlier, you know, if you catch the disease earlier, you think that you're extending the patient's life.
Okay.
You know, you include the earlier part of the patient's life. You know, if you diagnose it late, it'll be the same. You know, but finally, the survival is the same. The duration is the same.
Yeah,
But
this is a known problem with these types of studies, and also the fact that the systemic disease doesn't really sleep. So the systemic disease is very important factor, and of course, in this case, if we diagnose it earlier, the status of systemic disease may be better, so that it can be controlled very well, and the outcome of the treatment may be better. Of course, this bias is a problem, and especially nowadays when the patients when the technological advances allows us to diagnose them much earlier.
Yes. And also, you know, when they did these cell types, I mean, basically, like you have mentioned, they did only for the lung cancer and the melanoma, and they mentioned, you know, it doesn't make any difference when it comes to cell types. But there are so many other diseases, I mean, other cancers like medullary thyroid cancer and, you know, kidney cancers and all those things. So I mean, you know, you just really can't say exactly.
So there is still a lot to do, and many of these aspects there haven't been any clinical trials.
Right.
Like, for example, there hasn't been any clinical trial comparing stereotactic radiosurgery alone to surgery alone.
Right.
So the level of evidence actually for many of these aspects isn't that high.
Yeah, like you stressed, Kristine, there's no measurement for quality of life. There's no number for that, and it's hard to incorporate that into a study.
Yeah, and especially knowing that for the last one I mentioned, the clinical trial, it took them 11 years to get the number of patients around 200 to 300, and still they're struggling with the high variety of different factors influencing the outcome and the effectivity of different modalities of treatment. So it's a very complicated topic, and there's still a lot of things to do, and the paradigms will shift for sure in the future.
How long have you been involved in research in this area?
You mean the tumor research?
Yes.
Or?
Yes, tumor.
Yeah, I haven't been in Lamal for too long. It's been like maybe 2 years that I've been doing some research in cerebral metastases.
Okay, well, you've been involved in cancer longer than that, than cerebral, other types of cancer?
Yeah, well, mainly those are metastases, yeah.
Okay. Well, this is kind of a subjective question, and it's from a non-oncologist. Of the three areas, radiation surgery and chemotherapy, since things are changing in medicine with digitalization, what area do you feel is improving the most? Surgery, chemo, or radiation?
Oh,
Have you
well,
seen any significant improvement in one of these areas lately?
so stacks has been put on immunotherapy a lot.
Okay.
So this is something where actually the genetic subtypes, the molecular subtypes of tumor will in, and that would be ideal if we could actually aim the natural
Killer cells.
abilities of the organs of the immune system to kill to kill that cancer cells. And the immunotherapy is something on which the stacks is being put nowadays, and this is the area which is evolving. And actually, there isn't like certain chemotherapeutic agents which are very effective for the brain metastasis because of different factors, because of the blood-brain barrier, which limits the penetration of different chemicals, as well as the different subtypes of the tumors, which require different approaches.
So that's the area you see the most promise in the future.
Yeah, well, we hope on that there will be.
So it's promised, but is it leading, like, I mean, what treatment is leading right now? I mean, what is the best treatment that's available for the, particular type of tumor, or, these brain metastases? What is
So
leading?
yeah,
What is leading treatment modality?
so the leading treatment modality is the radiotherapy plus the
Radiotherapy.
surgical therapy. So that
Okay,
is
okay,
what we've been looking at.
okay. But the
So
best therapy
that's
is immunotherapy, right?
I can't tell because we haven't had any large studies which would prove their effectiveness, but there has been clues that this may be the area which is promising for the future.
Okay.
Very, very good. Kristine, I thank you very much for your taking the
Thank
time to
you.
put this together and the time to make this presentation. And we finally got to it. And I'll send you a copy of it. And thank you, Ven, and thank you,
Thank you.
Slavin, for participating.
Thank
And
you.
thanks, Christine, for a very clear presentation. I'd like to thank you again.
Yeah.
Thank you.
Okay, we'll end this presentation right now. Goodbye, world.